Fatigue is the most commonly normalized symptom in adults over 60, and the normalization happens not only in clinical consultations, where healthcare providers sometimes attribute it to age without specific investigation, but in the minds of the adults experiencing it, who accumulate the tiredness gradually enough that the shift from their baseline feels like the natural slope of aging, rather than a departure from it that requires explanation. The problem with this normalization is that several of the most important causes of fatigue in this age group are conditions whose trajectory changes meaningfully with early identification and management, and where the window for intervention that most significantly alters the outcome is the years in which the fatigue is being attributed to aging rather than investigated. Heart failure, whose earliest symptom is reduced energy, not chest pain or breathlessness. Blood sugar dysregulation, whose fatigue begins years before any diagnostic threshold is crossed. Sleep apnea, whose architecture-fragmented sleep produces the daytime exhaustion of a person who has slept 8 hours and recovered almost none of them. All of these produce fatigue as an early and prominent symptom, and all of them are manageable if identified rather than normalized. What I want to give you today is the 7 most important causes of fatigue in adults over 60, the specific features that distinguish each from the general background tiredness of aging, the 5 blood tests most likely to identify them, and the reason no adult over 60 should accept persistent fatigue as simply part of the territory without at least the basic investigation I am going to describe. Before anything else, what I share here is educational information only. It is not medical advice. Persistent fatigue warrants clinical evaluation, not only online research. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Subscribe to this channel now, because every week I bring you specific, grounded information about what your body needs after 60. The 7th cause is sleep apnea, and it is placed 7th not because it is less important than the others, but because it is the most commonly discussed cause, and because its distinguishing features are the most widely known, even if the diagnosis itself is frequently delayed. Sleep apnea produces fatigue through the complete fragmentation of sleep architecture, rather than through any reduction in the total time spent in bed. An adult with obstructive sleep apnea who sleeps 8 hours may have 30 or more apneic events per hour, each producing a brief cortical arousal that prevents consolidation of the slow wave and REM sleep stages, required for physical and cognitive restoration. The person wakes feeling as though they have not slept, regardless of the time in bed, because they functionally have not. The restorative sleep stages were systematically interrupted throughout the night. The distinguishing features of sleep apnea fatigue are the severe and persistent daytime sleepiness that is disproportionate to the hours slept, the morning headache from the overnight hypoxia and elevated carbon dioxide, the dry mouth from the mouth breathing that apnea produces, and the bed partner's report of snoring and breathing pauses. Adults who fall asleep easily during the day in low-stimulation situations, who struggle to remain awake while driving or watching television, and who wake unrefreshed consistently, have a presentation consistent with sleep apnea until proven otherwise. CPAP treatment for confirmed sleep apnea produces the most dramatic subjective improvement in daytime energy of any single intervention in fatigue medicine. Most patients treated with CPAP describe the first week of treatment as a revelation in terms of daytime alertness compared to their previous state, because the restorative sleep that had been absent for years is suddenly available. Type in the comments right now whether you have ever been told you snore and whether you have been evaluated for sleep apnea, because the proportion of adults in those comments who snore and have not had a sleep study is one of the most consistent indicators of how underdiagnosed sleep apnea remains in this age group. The 6th cause is iron deficiency, and the specific point I want to make that distinguishes this from a simple dietary insufficiency story is that iron deficiency in adults over 60, specifically in men over 60 and postmenopausal women, is rarely from inadequate intake alone, and frequently from a source of blood loss that requires investigation. Iron deficiency anemia in a man over 60 is a gastrointestinal blood loss until proven otherwise. The most common sources are colorectal cancer, peptic ulcers, angiodysplasia, and gastric cancer, all of which can produce occult blood loss insufficient to produce visible blood in stool but sufficient to progressively deplete iron stores and produce anemia over months. Iron deficiency in a postmenopausal woman is similarly a signal warranting investigation rather than simple supplementation. The fatigue of iron deficiency anemia is the fatigue of reduced oxygen delivery to every tissue. Hemoglobin, the protein carrying oxygen in red blood cells, is reduced when iron is insufficient for its synthesis, and the muscles and brain function at a lower oxygen availability that produces both physical fatigue and cognitive slowing. Even mild anemia, a hemoglobin modestly below the reference range, produces measurable reductions in exercise tolerance and cognitive performance in adults over 60 whose functional reserve is already reduced. The specific blood tests for iron deficiency are the full blood count, which shows hemoglobin and the microcytic pattern of iron deficiency, and the ferritin, which reflects total iron stores and falls before the hemoglobin drops. A normal hemoglobin with a low ferritin indicates iron depletion without anemia, a stage where supplementation and investigation of the cause is appropriate before anemia develops. The fifth cause is B12 deficiency, which we have covered in detail in 3 previous videos on this channel. In the specific context of fatigue, the mechanism is the impaired DNA synthesis in rapidly dividing cells, specifically the red blood cell precursors in the bone marrow, that produces the megaloblastic anemia of severe B12 deficiency. More commonly in the early stages, B12 deficiency produces the neurological fatigue of impaired myelination before any anemia is detectable. The specific clinical point for fatigue assessment is that serum B12 is an inadequate measure of cellular B12 adequacy, as we have established in our B12 videos. A serum B12 in the lower half of the reference range can be accompanied by functional B12 deficiency, as measured by elevated methylmalonic acid, and the fatigue of functional B12 deficiency can be present and significant while the serum B12 is still technically within range. Adults with fatigue and a borderline or low normal serum B12 should request methylmalonic acid to determine whether cellular B12 adequacy is genuinely established. And share this video right now with one person in your life over 60 who takes a proton pump inhibitor or metformin and has been experiencing fatigue for months or years without having had their B12 and methylmalonic acid assessed. Because the B12 depletion mechanism of these medications and the fatigue it produces is specifically relevant to this combination. And if you are not yet subscribed to this channel, tap that button now and ring the bell. The fourth cause is thyroid dysfunction, and both hypothyroidism and hyperthyroidism produce fatigue, which is one of the reasons thyroid function should always be specifically included in the fatigue investigation panel. Hypothyroidism, the underactive thyroid, produces fatigue through its reduction of the metabolic rate of every cell in the body. Thyroid hormone is required for the mitochondrial energy production of all tissues, and when it is insufficient, the metabolic engine slows, producing the fatigue, cold, intolerance, constipation, and weight gain that characterize the hypothyroid state. After 60, hypothyroidism is specifically more common. The cumulative rate of autoimmune thyroid disease from Hashimoto's thyroiditis increases with age, and the thyroid gland itself undergoes age-related changes in its functional capacity. Subclinical hypothyroidism, the state in which the TSH is elevated above the normal range but the free T4 is still within range, is present in approximately 10% of adults over 65 and produces measurable fatigue and cognitive slowing that responds to thyroid hormone replacement in symptomatic adults. The decision to treat subclinical hypothyroidism is individualized, but it is a diagnosis worth making with a full thyroid panel, including TSH and free T4, rather than TSH alone. Hyperthyroidism, the overactive thyroid, produces a different quality of fatigue. The fatigue of excessive metabolic demand and the catabolic muscle breakdown that hyperthyroidism drives, combined with the sleep disruption from its sympathetic activation, produces exhaustion despite the apparent high energy of early hyperthyroidism. In adults over 60, hyperthyroidism can present atypically as apathetic hyperthyroidism, with predominantly fatigue and weight loss, rather than the anxiety and tremor of classic presentations. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell. The third cause is medication side effects, and the specific mechanism I want to highlight is the cumulative sedation burden from multiple medications, each with individual sedating properties, which is one of the most common and most correctable causes of medication-related fatigue in adults over 60 on multiple medications. Beta blockers reduce cardiac output and blunt the sympathetic activation that normally provides energy and alertness, producing fatigue as a direct pharmacodynamic consequence in a proportion of users. Proton pump inhibitors produce fatigue through their magnesium depletion mechanism. We have discussed in multiple videos. Statins are associated with fatigue and myalgia in a subset of users through their effects on CoQ10 and mitochondrial energy production in skeletal muscle. Antihypertensives, including alpha blockers and central agents, produce fatigue through their reduction of sympathetic tone, and the anticholinergic medications, whose burden we have discussed in the context of dry mouth and cognitive impairment, also produce fatigue through their central nervous system effects. For any adult whose fatigue has worsened since a medication was started, or its dose was increased, a pharmacist-led medication review, specifically addressing the sedation and energy reduction burden of the current medication list, is the most efficient path to identifying whether medication modification could produce meaningful improvement. The second cause is heart failure, and I place it second because it is the cause most likely to be missed in the early stages when fatigue is the primary or only symptom, and whose early identification most significantly changes the long-term cardiovascular outcome. We discussed the early signs of declining cardiovascular reserve in our heart warning signs video, including reduced exercise tolerance and fatigue as the two most common early manifestations. In the specific context of heart failure, the fatigue reflects both the reduced cardiac output, the forward failure mechanism in which the heart cannot maintain adequate oxygen delivery to the muscles during activity, and the neurohormonal activation of the renin-angiotensin-aldosterone system, and the sympathetic nervous system that characterizes compensated heart failure, and that produces the inflammatory cytokines contributing to the fatigue of chronic illness. The specific features distinguishing early heart failure fatigue from other fatigue causes are its association with even mild exertion, the specific breathlessness on exertion or lying flat that accompanies the fatigue as the condition progresses, and its progressive worsening rather than the day-to-day variability of fatigue from other causes. An adult whose fatigue is specifically worse on physical activity and specifically better with rest, whose exercise tolerance has been declining gradually over 12 to 18 months, and who does not have any other identified cause of fatigue, should have a BNP or NT-proBNP blood test, which is the most sensitive and specific screening test for heart failure at the primary care level. The first cause is blood sugar dysregulation, specifically the postprandial glucose swings and the overnight blood glucose variability of insulin resistance and prediabetes that produce the fatigue and brain fog that most affected adults have been attributing to everything except the blood glucose pattern that is causing them. We have discussed this mechanism across multiple videos, including our post-meal blood sugar and peanut butter sleep videos. In the fatigue context, the specific experience is the afternoon energy crash that follows a high glycemic lunch, the morning fatigue and cognitive heaviness from overnight blood glucose instability, and the persistent background exhaustion of chronic mild hyperglycemia. The glucose-related fatigue is not from a single event, but from the accumulated cellular energy deficit of insulin-resistant muscle and brain cells that are metabolically underpowered despite normal blood glucose levels, because the insulin signaling required to drive glucose into those cells is impaired. The HbA1c captures the 3-month average blood glucose and specifically flags the elevated glucose range of prediabetes. But fasting insulin is the test that most specifically identifies insulin resistance in the years before HbA1c rises, because the compensatory hyperinsulinemia of insulin resistance maintains blood glucose within the normal range at the cost of progressively higher insulin levels. Adults with fatigue, afternoon crashes, and normal fasting glucose who have never had a fasting insulin measured may have been systematically missing the most specific test for the metabolic cause of their fatigue. Here are the 5 blood tests most likely to identify the underlying cause of persistent fatigue in adults over 60. Full blood count, which identifies the anemia of iron deficiency, B12 deficiency, and other causes, alongside the cell morphology that distinguishes between them. Ferritin, which identifies iron depletion before anemia develops and which should always be measured alongside hemoglobin in any fatigue assessment. B12, and methylmalonic acid, which identify the functional B12 deficiency that serum B12 alone may miss. Thyroid panel including TSH and free T4, which identifies both hypothyroidism and subclinical hypothyroidism and excludes hyperthyroidism. HbA1c and fasting insulin, which together identify both the glucose management and the insulin resistance that produce the fatigue of blood sugar dysregulation in the years before a diabetes diagnosis. These 5 tests, together with a clinical assessment that specifically explores the sleep apnea, medication burden, and cardiovascular reserve dimensions of the fatigue picture, address the 7 causes I have described. 4 things to carry away. Persistent fatigue in adults over 60 is not a natural feature of aging that requires no investigation. It is a symptom with multiple identifiable and treatable causes that deserve specific assessment. Heart failure and blood sugar dysregulation are the 2 causes most likely to be missed in the early stages, when fatigue is the primary symptom, and both are most effectively managed when identified before more characteristic symptoms develop. The 5 blood tests, full blood count, ferritin, B12, and methylmalonic acid, thyroid panel, and HbA1c with fasting insulin, address 6 of the 7 causes and provide the most efficient screening platform for fatigue investigation. Sleep apnea requires a sleep study rather than a blood test for its diagnosis, and its presentation of severe daytime sleepiness, disproportionate to hours slept, with morning headache and dry mouth, is the pattern to specifically request evaluation for. Share this video with one adult over 60 in your life who has been saying they are just tired from getting older and who has never had these 5 tests done specifically to investigate the fatigue. Because the investigation that reveals the treatable cause is the one that starts with the decision not to normalize the symptom. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that makes the symptom the starting point of an answer rather than the end of a conversation. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.